Hello, everyone, and welcome to Natural Language Processing to Address Social Determinants of Health. It's an event that Matter is putting on with IQVIA and NorthShore-Edward-Elmhurst Health. For those of you who are not familiar with Matter, we're a healthcare technology incubator and innovation hub with a mission to accelerate the pace of change of healthcare. And we do that in three ways. We accelerate the growth of startups. Since we opened in 2015, we've worked with more than 800 companies that have collectively raised almost $5 billion to fuel their growth. We also work with large organizations like health systems and life sciences companies and payers to help them achieve their innovation goals. Last year, we built and ran 8 cohort-based accelerators together with our industry partners, and this year we're on pace to do 10. We also work with the healthcare community to supply provocative content and ideas through a series of programs and events that are open to the public, like today's session. Today, we'll focus on the novel use of natural language processing to improve patient outcomes. So before we dive into the discussion, we're going to start with a brief presentation from Dr. Calum Yacoubian, who's Director of Healthcare Product and Strategy at Linguamatics, which is an IQVIA company. He will provide an overview of natural language processing and some of the things that they've been doing recently. So Calum, take it away.
Thank you very much, Stephen. It's great to be here. Thanks so much for organising this event. I know we've got a lot of people have signed up, and hopefully the content is going to be inspiring and interesting. So I'm just going to spend a few minutes just doing a little bit of scene setting before I'll turn over to my colleagues, Dr. Shah and Chad, to go into some real detail of how they're taking this technology and applying it. So I'm really just setting you up for the main show when my colleagues come on to present. So just as a little bit of a scene setter, as I say, and this is nothing new and nothing that any of us working in healthcare are not familiar with already. Healthcare data is incredibly complex and has huge amounts of challenges when it comes to trying to get information out from it. These challenges can kind of be summed up across what we see along the bottom of this slide. Big data, whilst it may be a bit of a tired term, is still extremely relevant and true within the healthcare setting. There's more healthcare data created than pretty much any other industry on a year-on-year basis. And the average amount of data that exists in a hospital is 50 petabytes, which, without going into any detail or without needing to know what your Greek prefixes are for data sizes, is a huge amount of data. 1 petabyte is the equivalent of like 4,000 4K movies. So it's huge volumes of data that are generated in the healthcare system or healthcare setting on a daily basis. In that data, most estimates have that 80% of it is in an unstructured or semi-structured format. So we're talking about clinical notes, etc., text-based data, which is very hard to derive information from. Confounding this even further is the fact that in your average healthcare system, there are between 15 and 18 different EMRs. This is based on a 2019 report from HIMSS. So we have this kind of three-way problem of big data, which is both messy and disparate, which explains why, quite sadly, 97% of that data is never used after its initial creation. And we know that healthcare data is hugely valuable for patient outcomes, for population health, for precision medicine, and for ensuring quality of healthcare that's delivered. I want to just spend a little bit more time focusing on the second pillar here, this unstructured element of the data. So what do we mean when we're talking about unstructured data? We're talking about these types of documents. So this is a synthetic example, of course, but any of us working in healthcare or have worked within a healthcare system will be very familiar with this type of documentation. Clinicians see patients, they take histories from them, and they dictate or they type them out. No matter how much we try to capture information in discrete and structured formats, we know that the majority of information which captures what happened between that clinician and the patient, which synthesizes all of the information from investigations, from treatment plans, etc., exists in this unstructured format. Now, we do know that alongside structured data, of course, for administrative and billing purposes, there is structured data, but it just doesn't come anywhere near close to capturing the true granularity of what's going on with patients when they're seen within the healthcare setting. So whilst this individual will have, of course, the presenting complaint hopefully coded, maybe medications, etc., and the lab results, you'd hope in some kind of structured format in the data, lots of the information beyond that primary diagnosis is left behind. And if we look at this document in a slightly different lens and we begin to sort of drill into, well, what types of information are we talking about? We can see that it's all of this disease stratifying information, not just that the patient has diabetes, but they have lifestyle factors that make them more likely for the diabetes to progress. They're already experiencing symptoms and signs, which the doctor has documented, which show that their diabetes is uncontrolled. We can also see some other social determinants of health creeping in here. We see that the patient has been missing appointments, that they have some social isolation, alongside kind of pertinent investigations and treatments that the clinician has felt are relevant to that patient's care. So not just an individual billing code or structured data is going to give you anywhere near this type of information, which we know exists in these clinical documents. And so we propose, and what we do at IQVIA within the NLP team, is provide a technological means whereby we can get at this data and make it available for downstream use. And of course, the topic of today's conversation is how do we look and find those social determinants of health and use them to drive health equity. So what is natural language processing? I won't spend a long time on this, but just to give you a very high level understanding, NLP, as it's called, is the ability to take all of that complex, unstructured text-based data and to convert it into high quality structured data for use in many different downstream applications. It's much more sophisticated than just looking for keywords. It's not like doing a Control F on your laptop and looking for the words diabetes. It's looking and searching for all of these clinical terms, and we use clinical terminologies like SNOMED and ICD-10, etc., to enable us to find these terms. But it goes beyond just the word search. It's looking for these within the context that the clinician implied or meant when they documented. So is the clinician talking about the patient, or is the clinician talking about a family history? These are different contexts, but very important to be able to extract them in the right way. Is the condition that has been documented something that's been negated? So have they said, she denies chest pain? Very different to presenting with chest pain. Or is it something the clinician has implied the patient may have? So, I suspect this may be pneumonia, but I'm going to refer for further investigations. Being able to pull out all of these concepts and terms within the context that they were implied is what natural language processing aims to do. And that's exactly what we do, and we provide software and services to enable organizations to get the most out of that data. And as I say, one of those initiatives is very much aimed at social determinants of health, as we're going to focus on as we go on today. So if we think about the document that I just showed you a couple of slides ago, that one document with all of that richness, we have it here on the left-hand side. And we think of that in the context of a patient's journey through a healthcare setting, through a healthcare system, not just in one encounter or for one condition, but over their duration of their care or of their health and illness. A huge amount of this type of data is created. Not only these admitting notes, but in fact, most of the diagnostic modalities, the information which we get from these additional tests that we refer for, the results exist in an unstructured format. So pathology reports with staging and with histology, they're all unstructured. Echocardiograms are unstructured. And when we refer for genetic testing and we have gene panels done, the results are very much in an unstructured format. NLP allows us to take this data and convert it into a structured, normalized form for use in a variety of different downstream applications. And we can see that this applies across diseases, symptoms, demographics, dates, measurements, everything here on the left-hand side, and very importantly, social determinants of health. So just looking quite quickly at who we are, why we're able to talk about this. So I represent a company called IQVIA, particularly a part of that organization called Linguamatics, which became part of IQVIA about 3 or 4 years ago. IQVIA is a large healthcare and life sciences organization that specializes in both the running and management of clinical trials, but also in the use of healthcare data and technologies to get the most value out of those data. We've been doing this with NLP for a long time, for over 20 years. So we have, in our team, people who are dedicated to the complex challenges of transforming healthcare data. into rich structured content for use in a variety of different arenas and a variety of different use cases. And as a result of that, we are very happy to see that many of our clients are the recipients of multiple different industry awards, kind of looking at how organizations are using technology in innovative ways to tackle healthcare data challenges. And North Shore Health are a really great example, as you'll go on to hear, of how they're taking a technological approach, but also looking at that last mile of how do you take that technology and implement it to tackle some of the real challenges that exist within the healthcare setting. And I think probably more importantly is that alongside these awards, there are over 100 publications of our technology being used. It's a very tried and tested capability that has been regularly peer reviewed. And whilst we support multiple areas and multiple applications, something that we're very passionate about and have been focusing a lot of attention on over the last couple of years is the use of NLP to get social determinants of health out of the medical record. There are lots of efforts, as we know, aimed at trying to get better capture of social determinants of health information. But we also know that a lot of this information is routinely captured within the clinical interaction between different members of the care team and patients. And in the majority of cases, that data only exists in the unstructured note. So think about an ED appointment, a nurse assessing a patient, documenting that the patient has been brought in by taxi because they live alone. That one statement would contain two social determinants of health pieces of information. And we're looking and using our natural language processing to mine all of these rich different EHR data sources in order to surface this information so that it can be used in the ways that you're about to hear about from Nirav and Chad. So I think I'm passing back to yourself, Stephen, just to introduce our next speakers.
Yes, indeed. And thanks so much, Calum. That was great. Terrific overview. So next, we're going to hear from the team you mentioned at NorthShore-Edward-Elmhurst Health. So Chad Konchak is the Assistant Vice President of Data Analytics, and Dr. Nirav Shah is the Medical Director of Quality Innovation and Clinical Practice Analytics. And the two of them are going to share an overview of what they've been doing with NLP and with social determinants of health. Thanks so much for joining us. Welcome, Chad and Nirav.
Thank you, Stephen. So again, I'm Chad, just to set the stage here for a little bit of what we're doing over here at NorthShore-Edward-Elmhurst Health. So you guys, this is kind of the topic of what we're presenting on today, using natural language processing to address social determinants of health. A little bit of background on kind of our new organization. NorthShore has recently combined with Edward-Elmhurst. So you can kind of see the blue versus orange here in our geography. We're 9 hospital systems serving over 1 million patients, which is about a third of the Illinois population. And you can kind of see, the service area here. I won't get into too much, but, pretty much very common, very large integrated healthcare delivery system. To set the stage a little bit, here's a quick story on U.S. life expectancy over the years. It's actually starting in 2014, we started to observe that life expectancy began to fall. So it actually didn't start during COVID, but very close. But then when we look at kind of the years around COVID and we disaggregate this information by something as simple by race ethnicity, we see that obviously people experiencing more kind of vulnerable environments kind of had a worse experience, right, with life expectancy. And if you were to look back historically, it's certainly the case that these populations were experiencing lower life expectancy than, for instance, white Americans. So obviously a big problem. Everyone's probably aware, but also it's not just COVID that was driving this huge decrease that we saw around 2020. COVID was a big part of it, but also drug overdose, homicide, diabetes, chronic diseases, and things like that. Not surprising to understand, right, that social determinants and the environments that people live in, or the environments that we thrust upon them is a big driver, right, of some of these things. So incumbent on health systems that, it's our mission to ensure that everybody is able to achieve their greatest health outcomes. that we understand these things and start to move it. The challenge is you might think that the North Shore is a very homogeneous organization, but actually if we look at life expectancy differences just within our kind of key market area, and this is just even the North Shore area, we see that there's about 22 years of life expectancy differences between the census tracts that have the longest and shortest life expectancy. So huge opportunity for us to understand what's going on here. Really understanding too that, right, what's driving these things, this is geography based, right, is not so much what we're doing within our four walls, but what's happening outside of our four walls. And it is kind of where people live, play, work, and pray that is likely driving some of these kind of most distant outcomes, but of course there's more immediate outcomes. So in the summer of 2020, we formed something we called the Health Equity Impact Team, very externally focused on our patient population, and the goal was to reduce healthcare disparities in the care that we provided across the continuum and to serve as a critical healthcare partner with community organizations whose work are aligned with the goals of improving equitable health outcomes. So an understanding that we couldn't do this ourselves and we needed to partner with community organizations, but really we needed to understand and describe the problem ourselves, right? You know, I had the chief medical officer kind of come into my virtual office and say, well, Chad, can you tell me where all our health outcomes, our social determinants of health and our equity outcomes are across everything we measure? And I had no idea how to do that. You know, this slide I've been using for a really, really long time. It was created to show the disconnect between what drives health outcomes and what we spend. But you know, really the things that we do within our health system represents about 10% of outcomes in health. You know, 20% are genetics. So, you know, choose your parents wisely. But largely the things that drive health outcomes, as kind of mentioned before, are these social determinants of health, right? The environments we live in and our behaviors, our choices, right? Or the choices society makes on behalf of us, the social determinants of health. And then again, this shows the kind of the disconnect between the spend, but I also think about this as Calum introduced, right? The data that we have. I mean, we largely lack a clear understanding of what's driving the vast majority of health outcomes, which is a huge problem. So for us, in addition to looking at community-based tools, census data, in fact, the graphic I showed you earlier with life expectancy came from a wonderful product called Metopio that gives us a good sense of what's happening in our communities at a geographic basis. But we really needed to understand what was happening internally. You know, like Calum said, a lot of our data is unstructured and we weren't really doing much with it. We have 3 different epics now across our large new system. And so this kind of capability is going to be critical for us to understand, you know, what's happening within our patients that are driving health outcomes. So I'm going to pass it off to Nirav, Dr. Shah, who's going to kind of talk about the very specific things that we're doing.
Thank you. And thank you, Stephen, for the introduction. And thank you, Chad, for setting the stage by illustrating the national and local issues around health disparities. The heat structure that Chad mentioned and that we've set up at North Shore is working diligently to reduce these disparities. And the IT arm of this team has been instrumental in this NLP work. So I'm going to walk you through how we're leveraging NLP insights to target workflows and drive efficiency. And I'll do so by starting with the use cases and then walk back to how we're actually doing this from the implementation side. So traditionally, the way that we leveraged SDOH was via unstructured and less likely structured documentation of elements that may come up sporadically in a conversation between a healthcare provider and a patient. There are structured fields that were developed by Epic some years back. And when we analyzed the likelihood that clinicians documented in these fields, we found an extremely low likelihood that these fields were populated, typically less than 0.1%. After NLP query development and extraction, we found that up to 30% of our population had at least one SDOH insight documented somewhere in unstructured text, showing there is value in extracting this information and making it structured to drive decision support. The emergency department has been a pioneer in collecting SDOH data elements, while Swedish Hospital, which is a part of North Shore, has been asking these questions regularly for some time. Given its designation as a safety net hospital, our pilot at North Shore started just in May of last year. We currently have an ED social worker manually collecting this SDOH data from patients at high risk of readmission and mortality, which is part of our prediction algorithm suite, which we call CAPE. And we have just gone live with our first NLP enhanced workflow to better target SDOH screening today. So today is the first day that we're actually leveraging this workflow that we're gonna I'm gonna discuss. How we're doing this is really the focus of the next few slides. The remaining 3 use cases and workflows are areas that we see opportunity and increasingly regulatory requirements to collect SDOH and where we think we can make the greatest impact. These include in navigating high risk and medically complex patients, ambulatory patients, and labor and delivery patients. These areas of SDOH collection are in various stages of pilots. We hope to take the learnings from our NLP enhanced workflow for the ED social work team and then bring that to these 3 areas in the future. Next slide. So this is a technical diagram to explain how we built the data pipeline that enables NLP insights back into our EHR to drive workflows. So all of the data from Epic, which is our EHR, flows into our enterprise data warehouse, or EDW. For our purposes, we're interested in our unstructured data within these clinical notes. And as mentioned by Calum and Chad, these notes are a wealth of information that is trapped and buried in narratives each time the patient encounters a new healthcare provider. These notes are fed through our on-premise Linguamatics platform, which, like Calum mentioned, is the NLP platform of IQVIA. This tool uses machine learning and rules-based approaches to extract insights. We have a fairly rigorous process of validating each of our queries from Linguamatics before we push it back as structured fields into our EDW. This insight is then fed back into Epic, where it can drive workflows and reporting. A few things I'd like to point out with this is we spent quite a bit of time thinking about the validation process and the degree of automating the NLP insights to drive prescriptive interventions. Some questions that came up include, how do we ensure the data from Linguamatics are reliable? How do we make sure our clinical team members trust these data? What is the best and also appropriate use of this insight? And how do we make sure that we're appropriate in asking sensitive questions and that we ensure that we are not prescribing interventions to patients based on false positive NLP insights? I'll delve into these questions in the next 2 slides. Next slide. We have 2 steps for the validation process, a retrospective process that is highlighted in this slide and that occurred before we pushed the NLP insights back into the EDW, and a prospective validation that is starting actually today. It will be based on the ED social workers making sure that the data from the NLP queries are accurate. For both of these processes, a feedback loop to the data scientist is key to ensure the algorithms continuously improve. To assess performance, a gold standard data set was created and the individual queries were run on this data set. Each query was then retrospectively validated by my research coordinators to determine if the query was accurate or not. And that validated data was then used by my data scientists to tweak the query and subqueries that made up each query. Just so you're aware, the Linguamatics queries are rules-based queries that are not a black box, so you can actually look at the individual components. So for example, you see food insecurity. There are individual sub-queries that make up what food insecurity means. And as a result, the team is aware of the strengths and weaknesses of each component to the query, and there's clear transparency as to how these work. So each SDOH query is a row in this table, and we assess precision, recall, and the F1 score. We found that our F1 scores were quite good, all above 70%, and they improved after some tweaking of the out-of-the-box queries. At NorthShore, we have a robust process for our metrics, and end users have been socialized around a scoring system that is represented by gold, silver, and bronze medals that represents different levels of accuracy. We leverage the same scoring rubric for each of our NLP queries, and we socialize that with our ED social work team and other teams that are involved in this. Next slide, Chad. We ran the final queries on a sample data set of 17,489 patients and found results that showed that up to 31.73% of patients had at least one SDOH insight, such as living condition, which was a marked improvement from our prior source of structured SDOH fields in Epic with less than 0.01 capture. Next slide. Okay, so with the queries finalized from the retrospective validation, positive results over the last 6 months are stored back into Epic and are displayed in the list that determines whether the ED social worker should approach the patient for standardized assessment. We have other modalities of identifying which patient should be approached, including whether they are high risk of readmission or mortality through our CAPE algorithm, and also if the ED nurse identified a need requiring social work assistance. Next slide. The ED social workers complete their assessments in flow sheets by noting if there are SDOH gaps. Query validation questions appear at the bottom of this assessment and is shown in the bottom figure. So here is the perspective validation component of this workflow. Social workers can add comments, and this data is fed back to the data scientist to help with query improvement. Also, social workers and the data scientists will routinely meet to discuss the queries and validation. If a query is validated to be incorrect via the Linguamatics validation flowsheet rows, then if a patient returns to the ED in the future, the Linguamatics insight will not be identified and the patient will not show up on the list unless there are other reasons for them to show up on the list. So going back to the initial questions that I posed, we have a two-phase validation process, which is similar to what we do for all our predictive analytics algorithms at North Shore, with a retrospective data validation and a prospective validation in our EHR Epic. We decided not to automate the interventions at this stage because we'd like to prospectively validate our queries and because we believe we can continue to improve the accuracy of these queries. At some point in the future, there may be opportunity for automation of select queries if we feel as though it is safe and appropriate. So for example, if we find that the transportation query is fairly accurate and we're able to appropriately perform the interventions, we may automate that in the future. And our ED social workers have been aware of these steps we are taking to ensure performance and reliability, and they not only trust the insight and process, but are excited to get started and believe they'll be more effective and efficient in their ability to identify patients with SDOH gaps that can then be addressed, resulting in improved outcomes. We've actually been part of a chain today where the ED social workers were essentially commenting that there's additional patients that are showing up on the list, and they're excited to kind of get started on this. So with that, next slide. We'll open it up for questions and answers.
Well, thank you. Thank you, Nirav. Thank you, Chad. And with all that background, we're going to dive into the discussion. So I'd like to welcome our moderator, Dr. Kathy Bobay, who is Professor and Associate Dean for Faculty Affairs at the Parkinson School of Health Sciences and Public Health at Loyola University, Chicago. Her research focuses on the impact of nurses on improving patient care. We have a terrific relationship with the Parkinson School. I'm delighted, Kathy, that you're able to join us, and I will turn it over to you to moderate the discussion.
Thank you. Great presentations, everyone. There are a couple of questions, so I'll start with those, and then I'll fill in with some of the questions I have. One of the participants says, wonderful insights. Curious if you can share how you factor in the digital divide, social determinants of health barrier in your use cases, either in terms of the patient barrier to accessing care or to other similar social determinants of health. Probably, Nirav, that might be yours.
Sure. So a lot of the use cases that I kind of listed were touch points between the patient and the provider. So whether they show up to the ED, whether they're showing up to ambulatory clinics. So there isn't really kind of a digital divide that's occurring by showing up to these different types of clinical events. You know, specifically in terms of the actual algorithms, is there bias in the algorithm? I'm just kind of taking it a step further to that. You know, again, this is not a black box. So we have the ability to understand all the components of the queries and the subqueries. And that's why we are, in addition to the retrospective validation, we're looking at a prospective validation to determine if there is going to be any kind of bias in, you know, these algorithms.
Thank you. That actually answered one of the questions I was going to ask about potential biases. So it sounds from your description that the process is near real time. So based on questions that are asked, it moves through the process and comes back in a way that it can be used immediately? Or does it access, for your pilot, does it access data already in the system?
So I can take that. So essentially we've run this query on all our patients, and that insight is back in our EDW, which then gets populated into Epic via data elements. So anytime any patient walks in and that data element is present for that patient, it will show up in real time in the ED. So it is essentially a real-time indicator if someone has an SDOH element identified by the Linguamatics tool.
Thank you. I don't remember whose slide this was, Chad's, I think. Did you compute the negative and positive predictive values for each of the social determinants of health?
Yeah, we presented that on the slide. I could bring it back up. We named it differently, precision and recall, which are very similar to those metrics. And to the other question, I think that was on there, definitely can share the slide deck through Matter too, so that you guys can see that.
Thank you. I think this one's also Narav. Did your team look at any connections between specific social determinants of health and health disparities? And did you consider other models other than NLP?
So I guess I'll take this, and then Chad, you could jump in. So specifically for this, we have focused on this single workflow. So we've focused on building out the, or rather tuning the out-of-the-box queries from Linguamatics, validating them, and then pushing it through this workflow. We haven't attached these insights, as far as I'm aware, to other types of workflows. I think Chad can speak to maybe one or two that he's more involved with. So Chad, if you want to.
Yeah, I mean, just speaking more broadly, one of the earlier challenges was, how do we define health and equity in terms of our measurement systems, right? I mean, I think we could all kind of find a textbook definition, but, we as a health system, all health systems measure a lot of different things. And we have, I think, 135 different corporate scorecard metrics. And so then this question of where are inequities within those measures, a really complicated question began to arise. Was like, well, what does that really mean? How do we define, I'll just use, for example, breast cancer screening, because that was one of our cases. How do we identify and even just define what inequity within breast cancer screening is? People jump to race, ethnicity, but of course, that's problematic for a lot of different reasons. And in fact, our data isn't even that great in collecting that accurately. So we also looked at geographic levels of information, back to kind of the map I showed. So we disaggregated all of our information based on data at a census tract level to represent the communities that people live in, so that we could see the differences in breast cancer screening rates between the wealthiest communities versus the poorest communities, using, for instance, census tract median income. So there was, I think, a really difficult kind of definition discussion. And by the way, to the previous question about how do we decide on what use cases, the health equity impact team was represented by, physicians and nurses and operational leaders across the entire system, split into an ambulatory and acute care subgroup. So there's a lot of input on all these things. And then maybe more to the question at hand, for breast cancer screening, really, obviously we had some, predefined hypothesis driven things that we felt were social terms of health, like obviously transportation, the time that our clinics were open versus not. And then that helped inform what we were looking for. But also, certainly found things like language being a really poorly documented thing in our EMR. That also then was a feedback to the group to say, hey, this is another opportunity. If all we're doing, for instance, is sending messages through our Epic MyChart app, which, by the way, that in and of itself was really inequitable, but it's also all in English. At best, we're ignoring inequities. At worst, we're exasperating it. So I think there was a good feedback loop between the teams that are on the ground trying to solve these problems, and then the data that we were pulling, both from a descriptive analytics and then from this NLP perspective, to work together to prioritize and identify what social terms of health we wanted to start with.
Thank you. Another question, which I think most all of us could answer. The attendee is surprised by the amount of unstructured data. Is this standard across other EHRs? And I'll just, from the work I've done, this is a pretty standard metric that 80%, regardless of the EHR that you're using, is pretty much the amount of data that's in narrative notes. But I'll open it up if anybody wants to add anything to that. Calum?
No, I mean, yeah, that's what we see pretty much across the board. We work in multiple different countries as well, and so there are some places where the number is potentially higher. Obviously within Epic, there's and the other big EMRs, there's a great effort to try and capture as much discrete information as possible. And I think the stat that Neera presented is, I mean, it is not like this for everything, but a 0.1% fill rate for social determinants of health. You know, that is a fairly staggering number, but at IQVIA, we actually do some broader data aggregation from a very large number of ambulatory EMRs. And again, we see the fill rate for social determinants of health when we look at the kind of designated Z codes that exist for social determinants of health to be in and about that 0.1% number as well. So it's not surprising. But yeah, when it's the first time you've heard it, I guess it is a bit alarming, especially if you do a lot of work in an EMR, which is constantly trying to force you to do things in a structured format.
Thank you. The next one, I'm not sure we can answer here, probably for Chad. How do you create a EDW from Epic? And how do you put the data extracted from Linguamatics back into the EDW? Seems like a really big question.
Yeah, I'll try to generalize. You know, so right, in any kind of analytics processing, it's the EMR is our transactional system, right? Not as well built to do analytics on broad populations. So we pull all of that data into our own enterprise data warehouse. Certainly Epic and other EMR vendors have their own version of a solution for this. It doesn't really matter, but it's data that's more organized to support analytical questions versus transactional questions, like one patient at a time, revenue cycle, and things like that. And so that's kind of where we're starting to get access to these large amounts of data. And then that's where we hook on the Linguamatics platform that is really the key engine that's turning the raw material into the insights, right? And then once we have that nugget of insight, there's the data engineering to put that back into the electronic medical record, which is the cockpit of where our clinicians work. There's probably a lot of different ways you could do this. And in fact, kind of removing our data warehouse as the intermediary and doing things in even more real time, I think would be an advanced version of all of this. But during the piloting phase and the validation phase, having our data warehouse there to facilitate this was really helpful. But again, just our solution to it does not by any means have to be the only way that one could kind of stitch all this processing together. I guess I would just say is absolutely critical that things make their way back into where the cockpit of where our clinicians work, which for us is Epic.
Thank you. Probably Narav, or maybe Calum, have you found one of the indicators making the most difference? I'm guessing it's one of the social determinants of health more important than any of the others in making decisions.
So our workflow is just identifying patients who may have a gap so that an ED social worker can, do a manual questionnaire and identify, what issues the patients have. I did kind of show you a graphic that showed maybe 5 or 6 different S2H elements that we have extracted. There's at least one there, living arrangements, where that's flagging about 30% of patients. So just in terms of frequency, we're seeing that kind of bubble up to the top. And that's one of the things that our ED social workers are going to be addressing. So just from a prevalence standpoint, not necessarily kind of like a weight in which is the most impactful, but from a prevalence standpoint, that seems to be the one that we're finding to be the most prevalent.
Thank you. This is probably Calum, I would guess. Can the software be applied to screen patients for research recruitment? Same procedure, but different parameters.
Yeah, it can be. So the software itself is very flexible and is used for a lot of different use cases, and screening patients for clinical research is one area that quite a number of our provider clients use it for. On the flip side, we have a lot of clients that are pharmaceutical companies that are using it for knowledge discovery, and they're using it in the fact to kind of build effective protocols. So, screening the literature, screening preprints, and different sources to build effective protocols that kind of reflect the real world. So we work kind of on both sides of the clinical trial paradigm. Yeah, and many other use cases, it's used and certain coding procedures for payers are using it, and things like risk adjustment, and providers are using it to support, clinical documentation improvement in areas such as risk adjustment, identifying phenotypes to support rare disease diagnosis, tagging those notes to things like the human phenotype ontology. It's got lots of broad applications. Yeah.
Thank you. The next question, I think, is for Nirav. What resources do you have to respond when you identify the social determinants of health? That's a big question.
Yeah, that's probably a topic for an entire presentation like this as well. So our ED social workers, kind of live in the community. They know the area. They know kind of what local resources exist. They have little binders where they aggregate things. And now more, increasingly we're seeing there's startups and companies that are essentially aggregating these resources and providing an interface with, Epic and other electronic health providers so that you can connect a specific SDOH gap to a specific kind of NGO or some kind of provider that can address that.
Okay. Thank you. Another attendee asks, probably this might be for Chad, what kind of outputs do you provide? Do you use structural maps or other visualizations? How does it come back to the example of the ED social workers? And so maybe we'll do that question first.
Yeah, sure. So if you remember kind of the technical diagram that we saw, right, with, and I described this before, the kind of data engineering to kind of get that insight, and then that key step of putting it back. Obviously, there's the point of care workflow, the AI at the bedside, let's call it. And importantly, by the way, right, this is really augmented intelligence, right? We are not, and sorry to deviate a little bit, but I want to make this point. Like, we're not telling Epic that this person automatically from the machine has a transportation issue, right? It's more of like a predictive model, right? It's saying, hey, we see evidence for this, but the judgment, the gestalt of the clinician reigns supreme, right? So, and I think that is a core philosophy of how we do these things, right? And I think it should be for everybody. But right, there's that point of care bedside workflow, but then also we have all of those kind of nuggets of insights then for our entire population of patients. So there's that other stream in that diagram where, coming from our data warehouse, we build dashboards and reports. For instance, we have something called the Lens of Equity tool that allows us to visualize all these things, either in the context of specific metrics, right? So like breast cancer screening I gave as an example, but also geographically, right? Where are these transportation issues most prevalent? Because that could inform then, partnerships, for instance, with specific community organizations that are obviously localized, or things that we want to do maybe at a community specific geography that might differ, right? As you saw with the life expectancy slide, not all individuals in our communities are experiencing health and health outcomes the same way. So it's a great question, because visualizing this stuff in the context of our geographies, our patient populations, the things that we measure, is a key part of the kind of descriptive analytics that we do on the side. And then separately, I'll just note that we actually prioritize on our corporate scorecard, not just the outcomes themselves like breast cancer screening, but we have held ourselves accountable to reducing the inequity within some of our measures as a core outcome. And that's, I think, an increasing philosophy and theme that we're starting to implement in our, the goals that we set for ourselves.
The second question posed is, how much variability is there, adapting that's required from project to project? So you identified several use cases. How much different are the models between use cases?
That's a great question, and something that we're going to be thinking about, because some of these are future use cases. But the basic concept of identification of a potential SDOH gap can be used across all of those use cases, whether for an OB patient in the ambulatory clinic. We're just kind of in the early stages of just seeing how this workflow can be leveraged for identification. But for the prescriptive intervention piece, I think there's a lot of opportunity there that we'll be able to exploit as a result of the learnings from this initial pilot that we have.
I'll just add on to that, Kathy, if it's okay, because I think, you know, we've got a lot of experience of taking some of these models from to different organizations, and also seeing organizations grow that we've been working with over the past sort of 10 or so years in healthcare. And, you know, the question comes from a good place. You know, it's very rare to take something like this and drop it, and, you know, you're getting 95% precision and recall on day one with no optimization. And a lot of the work that Nirav, Chad, and team have done has been ensuring that they're getting those accurate results on their data. One of the ways that we approach NLP is to try and make that increase of precision and recall to what's acceptable for your organization as quick as possible. And we use, like, I think as Nirav actually said, a blend of methods. So we are using, you know, some machine learning ontologies and rules, which enables you to kind of get that precision and recall up without the burden of huge volumes of annotated data. Because a lot of approaches to kind of text mining, NLP, rely upon that. And, you know, annotating data takes a long time, and coming across annotated data for every use case can be something that is prohibitive for different methods. So we try to take a very flexible approach to let people get what they need in terms of precision and recall.
One other thing, a lot of the insights that we're going to gather going forward is going to come from the frontline providers, the social workers, the primary care providers, the OBs. Just putting a tool like this in front of them will create significant ideas on how to use this and how to leverage this. And we've seen this with other types of AI tools that we've had. So I think there's a lot to learn from our colleagues that are, you know, actually in the weeds doing this with, you know, talking about these issues with their patients and learning from them and figuring out how to operationalize them.
Are you going to be looking, I know you're just starting the actual pilot today, but are you going to be looking at correlations in social determinants that might infer other needs that maybe weren't asked or were not captured in the clinical notes?
I mean, I think these are great questions, and I think that's why doing these types of presentations are great, because not only can we provide information, but you guys can make us think a little bit about, you know, where we want to take this. I think that's a great point.
Yeah, one thing that we are starting to do and look at is, you know, we have a long history of developing risk models, predictive models, like for readmission, for instance. Everyone's got one of those. And now think about the power all of these added elements might be in predicting outcomes better, or not just in terms of risk adjusting people or risk stratifying people, but even segmenting people, right? So you might have two individuals that are both at high readmission risk, but there might be elements of social determinants that might very much inform the kind of how we address you know, the intervention, right? Because it could be that they're, you know, frail and elderly, which is causing them to get readmitted, which is just one kind of solution, a bucket of solutions. But alternatively, it could be a lot of social determinants, you know, language issues, medication understanding, et cetera, that could be driving that readmission, for example. So I think putting this as thinking of the NLP as a pre-processing engine to build better elements that then can be built into a predictive model is something we are looking at, and kind of another way to leverage all this technology.
And the design of this intervention was such that we are collecting all of this information. So we're collecting the information from the ED social worker. We're collecting all the NLP insights. So that type of analysis, it's all possible. The pipelines are already built. And so I think we'll have to see where this goes.
I think you at the next question, actually, speaking a bit more about the machine learning going on. I think this probably also gets to how do you tweak your algorithms over time to make them more accurate. Chad,
yeah.
Or Calum, either.
I mean, I can talk to the out of the box algorithms. So there was a question earlier about precision and recall. So we kind of, whenever we're releasing anything, want to ensure that it has a good baseline F score, which is the sort of the mean of your precision and your recall, or your specificity and sensitivity, or your negative predictive value and your positive predictive value, depending on what day of the week it is, which one of those you choose. So we are always ensuring that we have, you know, a high degree of accuracy, and we're always updating it. So we release our software quarterly, and as we do that, the underlying ontology, like clinical terminologies that we use, so SNOMED, ICD-10, they're obviously updating their data for things like Z code. So we ensure that we're keeping current with that. I think maybe, more to Nirav and Chad can talk about how they may, moving forward, kind of periodically ensure they're still maintaining those F scores that they've got currently.
So I mentioned that there were two validation phases. So the retrospective validation, there was a lot of tweaking of the queries to get it to kind of a level where our data scientists felt like it was ready for deployment. And then obviously there's the prospective validation where she's going to get direct feedback from the ED social workers in kind of real time to further tweak to see if there's components to the language around some of these queries that can update and improve the accuracy.
The next question is a great question. For each category, how did you provide the care managers with some sort of algorithms, or how do they decide what interventions to do? The example is there are many factors about food security. How have you helped the care managers to decide how to help the patients?
So we're not changing anything from the ED social workers workflow. So they already have pathways that they have internally for addressing each of the conditions that they're supposed to focus on. Via these tools that exist in our electronic health record, partnering with some company that is identifying, for food insecurity in these areas, it's identifying some food banks, et cetera. So all of that is unchanged. Really what the technology is doing, it's identifying patients who would have not otherwise been identified for the ED social work to approach to then perform their manual process.
Thank you. The next attendee, this is probably for Calum. What's the best training if a young person wants to learn how to use NLP to enter the field?
What's the best training? It's amazing how much there is online. So there's a huge amount, even in things like LinkedIn Learning, if you have access to that. I didn't start off in this space, so I'm a clinical doctor by background, and I have kind of found myself working now in NLP. And you actually can learn, depends what your baseline is, but you can learn a huge amount from things like YouTube and tutorial videos. That's a lot of what I've done. And if you want to go deeper, there's obviously a huge amount of literature on the different models that are used. But that's not a great answer. And if there's a young person who's wanting to get into NLP, I will invite you to email me after, and I can maybe try and help set you up with other bright young people that work in our company who have found themselves working in NLP more in the nuts and bolts of what we do. So I will try and get you a better answer from people who have trod that path in a more traditional sense than I have.
Thanks. How much time on average does Linguamatics take to process a single note?
Like for a single note, like it's milliseconds. So it depends. We have a very scalable architecture. We have clients processing 8 million records per hour. If they need it, most instances, require processing of large volumes of data. So you're processing, thousands, hundreds of thousands, depending on what your use case is, what kind of setup you have. I'm not sure actually, Nirav and Chad, not sure what setup you guys have and what processing speeds you've seen. But yeah,
I have some stats, but the main point, look, it's all about how much horsepower you're putting behind this, right? We set up a dedicated server. I don't have it in front of me, but I could share that offline. But the way we have it set up is we can process about a month worth of clinical notes in about 2 hours. So that translates to about 300,000 documents an hour. And so we could obviously ramp that up with more computing power, right? But that's pretty good.
Yeah.
probably another question for Calum. Is the software considered to be a medical device?
No, not in the way that it's currently used. So most of the use of our NLP is about supporting decision making and supporting what are currently manual processes. So if you think about it in the case that Nirav and Chad have spoken about, you're using NLP to surface insights to be actioned by social workers. We don't have any use of our NLP currently where you have a black box where NLP is taking in data, then making a treatment decision. If that were the case, it would need to be regulated as software as a medical device. So no, not currently. In future, could it be? Potentially, but most of the use of the tool is, as I think Chad mentioned, it's very much augmented intelligence as opposed to standalone artificial intelligence. So we're augmenting experts.
Okay. Once I'm not sure who, maybe Chad. Once the unstructured data that you extract from Epic is structured, then do you send it back to Epic? And
Yep, right. So that was that diagram we shared, right? All of the raw unstructured data goes out of Epic into our data warehouse. It gets enriched by Linguamatics, and then we have that nugget that Chad has transportation, and then that gets sent back into Epic, actually through a process called data link, and associated with that patient's clinical record. As technically it's called a smart data element. But again, importantly, like Calum said, right? Like, let's say it was language, we're not overwriting their demographics section. Like, that would be a big no-no, right? It's this just subtle element that allows us to suggest that this should be investigated further, right?
The next question also might be directed at Chad or Nirav. How is this approach being integrated with chronic care management, since those two things are integrally linked for many patients?
So that's one of the future use cases. So within the ambulatory use case, chronic care management will probably be the starting point because they tend to have more resources to be able to address this, and their populations are a little bit more complex. So we're going to see, again, part of this is going to be, do we leverage a similar type of workflow where we identify certain areas of SDOH gaps, and then those are, further queried to understand what the issues are? Or, can our, wonderful CCM type physicians and nurses and social workers help us identify novel workflows that, that can accelerate the work that they're trying to do?
Thanks.
Thank you so much. We have lots of questions still from the attendees, which is a good sign that people are engaged and interested. We'll see if there's a way for us to pull those together in some way. We have access to them after the fact. Thank you, Kathy, for moderating. Thanks, Calum and Rav and Chad, for kind of really a rich look at how we can use NLP to improve outcomes through assessments of social determinants of health. And thanks everybody for joining. So if you enjoyed today's program, you might want to tune into a couple ones we have upcoming. We have one on Thursday. It's our inaugural 51 Labs final showcase, where we'll hear 11 startups innovating in menopause. We have one on April 12th, where we'll be featuring an entrepreneur, Stephanie Tillinius, who's the CEO and founder of Vita Health. You can look at matter.health/events for information on all of our upcoming programs. And thank you, everyone, again for joining, and we hope you enjoy the rest of your day.